Hello, welcome to the Dr. Paul Show. Today I'm going to be telling you my story in brief. And if you like what you see, please like and subscribe to the show. And please help us grow. We really appreciate it. So welcome to the Dr. Paul Show. Today I want to kind of back up and tell you my story in brief from the beginning. And so my story really starts back in the mid-late 80s, really. I started, I did my undergraduate degree. I got an undergraduate degree in biology from USC, fight on, Trojans. Then I went to New York for medical school. And I was always interested in a variety of topics. And when it came to, towards the end of medical school, you have to choose what you're going to specialize in. At the time, I really didn't know. I liked pediatrics, I liked adult medicine, I liked OBGYN, I liked a variety, I liked psychiatry. There was nothing that I thought I wanted to do full-time, so I chose becoming a family doctor because I thought that would give me the best variety of things to do, and it would be most interesting to have a multitude of problems to try to solve. So I did a 3-year family practice residency program in Los Angeles, in California Hospital from 1989 to 1992. And at the time, I was really interested already in psychiatry. At the time, we had the modern antidepressants. The first one was Prozac, which is a lot of people know that one. That was really the first modern one. The ones before that were basically kind of cruder medication, not very well tolerated. So a real revolution in the field is when the SSRIs came out. So which stands for Selective Serotonin Reuptake Inhibitor. Before I actually get into that, let me back up a little bit more and explain what's going on with the nervous system. So the nervous system in the body is composed of neurons, which are nerve cells communicating with each other. So a nerve cell under an electron microscope looks somewhat like this. And so what's going on is that there's chemicals traveling from neuron to neuron at a rapid rate constantly in the system. There's over 100 billion neurons in the body. The chemicals travel around the system about 1,000 times a second, if you can believe that. There's the space in between the neurons that we call the synapse, which is there's over 100 trillion synapses in the body. So a lot going on at a very rapid rate. So that's kind of where, when it comes to medications, and we'll get into a moment of how they work. But basically with SSRIs, what we discovered was that there was a problem at the serotonin site. So if you look at what it stands for, Selective Serotonin Reuptake Inhibitor, so we're inhibiting the reuptake of serotonin, meaning that serotonin is going the wrong way, backwards, instead of the right way. So when we give an SSRI, it blocks that. It blocks that reuptake, and it forces that chemical to move forward. And they were working. And when I was in training, we had Zoloft. The second one was Prozac. Excuse me. The second one was Zoloft, and the third one was Paxil. And I had some good experiences with them. Paxil was a little bit iffy, not very well tolerated. Prozac and Zoloft were decent medications. The problem with them, though, is that they would help certain people, and some people they didn't help. Some people they had side effects, which were unacceptable, like sexual side effects, and most people, especially guys, are not going to put up with that very long. Some people, it makes them feel kind of flat, apathetic, lack of emotion, sometimes weight gain. But some people felt like, well, at least my depression is a bit better and I'm not as anxious, so I'll put up with the side effects. It was all that we had. And so they had to kind of weigh the negatives and the positives and make a decision. Some people just wouldn't say, I don't want to take it. And then they just live with their condition. There's nothing they would do about it. Or some people would take it and suffer the consequences, but because feeling like, well, the depression's worse than the side effects, so I'll take it. A very revolutionary thing happened I started practice in 1992. A year after I started practice in 1993 was the first SNRI. So it stands for Serotonin and Norepinephrine Reuptake Inhibitor. So, and it was called Effexor XR, and that was probably the most significant breakthrough in my practice, probably since then. Because the reason for that is because it really showed me that there was more going on than just mood. So I found out that when you balance serotonin and norepinephrine at the same time, some very strange things were happening in my practice. So people were coming in and telling me, "Doc, what the hell did you give me?" I go, "Well, why?" Well, she said, "It's way better than the other one you gave me." And not only that, and my anxiety is better too. I'm not as depressed still, but my anxiety is better. I actually have less side effects. I feel more emotion. I feel less flat. But what's really interesting is my neck and my shoulder pain that I've had for years is gone, and my headaches and my irritable bowel syndrome. When I get stressed out, I usually get real bad bowel issues, and I get chest pain, and I get sweating, and I get all these anxious feelings, and those are better. But what struck me as a family doctor is that they were physically feeling better. And I thought, well, I tried to make sense of it because the Effexor company that made it, they didn't talk about these things. And I went to speaker training to talk to doctors about it. And when I was even there asking them, well, why aren't you talking about, well, we can't talk about that. We can only talk about depression because that's what we're indicated for. And that's the way it is in medicine with medications, is they can only talk about what the FDA allows them to say. And if they can't say anything about anxiety, they can't say anything about the body. So basically, I think what happened is doctors would just never hear these things. They never heard the difference. And I think the doctors got in their mind that there was more side effects with it. So there was a nickname called side effectsor. Because I think the reason is because the company was telling doctors that you got to push the dose. If you stay at a low dose, it's no different than an SSRI. You have to get the dose up high for it to really be different. And I started seeing that wasn't true. I started seeing that even at the lowest dose, I was seeing improvement. At the second lowest dose was the most common, it still is the most common dose I see, was really good. And the third most common dose, this third dose, is sometimes you start to get more side effects, sometimes you don't. And sometimes you get to the highest dose and they do great. But a lot of people do better lower, and I think doctors were probably listening to the company about pushing it too quickly, and they see side effects and they got scared away, and I think doctors go back to their regular habits. And as a family doctor, I think I was really noticing it because I was looking at the body, because that's what we family doctors do. We think about the physical symptoms of the body. I think psychiatrists missed it because they're thinking about the brain, but they don't train on the body. When they're with psychiatric training, they don't study primary care medicine. They don't study any of those things. So I think that's why it's been missed for so many years. And even to this day, over 33 years later now, people still don't understand the difference. And all the studies we're seeing, when they come out with new medications, all the studies are still based on SSRIs, and it's unfortunate. I think there was an opportunity missed there, because I think if that simple message would have been understood early, it could have changed a lot of the whole trajectory of this field, but it didn't. But I saw it, and what I saw it again and again. So during the 90s, I was really amazed with what I was seeing, and so that was one thing. And then we also had Wellbutrin. So some people with Effexor, which really helps with anxiety, depression, and pain, but sometimes, like with SSRIs, not as badly, still feel tired, a little bit apathetic, sometimes depressed still, lack of motivation, sometimes sexual side effects still, even though it's not as much as SSRIs, it can still happen. So then I started understanding Wellbutrin, an ND is the only NDRI. I put a little n here because it really only works on norepinephrine a little bit, not a lot, not like Effexor does. So a little bit of that, but really the focus is really mostly dopamine. And when you balance dopamine, I call it the pleasure chemical, or I call it the sex, drugs, and rock and roll chemical, because when you put Wellbutrin in the mix, it just wow. I call it the wow factor. And I call the SNRI, like Effexor Wellbutrin, or now Prestige Wellbutrin, I call it dynamic duo, because when you combine those two, you got all three of these resolved at the same time. And that's probably the most common combination I put together in my practice, even to this day, is that combination. So, and then the only SNRI for a decade was Effexor, before the next one came out, Cymbalta, in the early 2000s, and then Prestige, and then Fetsima. So there's four of them now in available. So what also happened in the 90s was that I started understanding really early on a medication called Topamax, and then there's another one called gabapentin. So these work on the chemical called GABA, and GABA is gamma-aminobutyric acid. So that's this fourth one is GABA or glutamate. Another one is, so they both work on GABA or glutamate. And so with Topamax, gabapentin, when you start balancing GABA, what does that do? Well, it helps with anxiety, it helps with pain. Topamax, so I still prescribe a lot of gabapentin and Topamax. Topamax is very unique because it also works on GABA, but it also works on anxiety and pain, but the advantage of that one is it can help with weight loss. And so, now in the age of semaglutides and everyone wants to lose weight, it's a very, very good medication. Why? Because it reduces the desire for sugars and carbohydrates. So a lot of people eat these foods in the evening. They have a craving and they binge in the evening. So I started understanding that you give Topamax like in the early evening before the binging starts, and it really, once you dose it right and figure out how to dose it properly, it can really make a huge difference. Now, a lot of doctors, they call it Dopamax, because of the fact that if you go too high, it can make you, we call cognitive side effects, and make you kind of spacey and foggy brain. But the problem is, I think it gets a bad reputation, and doctors don't realize that you have to dose it the right way. And I figured out the right way to dose it properly, to figure out the right dose without the side effects. But that's been an invaluable medication that I've used in my practice for over 30 years now. So what else happened in the 90s? A lot of things happened still. So I started, the first we call atypical antipsychotic is called Risperdal. That came out, I think, in 93. So about a year after I started practice, I started with Risperdal. So there's also the class called I won't draw it out here, but it's called the dopamine antagonist. So in the case of Wellbutrin, dopamine is going the wrong way, we got to go the right way. In the case of some people, it's going too fast. It's going too fast, and we need to slow it down. We need to, so when we antagonize dopamine, it means we need to slow it down. So that would be people sometimes who are manic or can't sleep well, their mind is racing, and that can lead to psychotic thinking, that can lead to some bad stuff. But when I was first, and since I was already kind of getting a reputation by that point, and I was starting to understand with Risperdal that people were getting better some people who weren't getting better with my cocktail here, or were getting worse with these, I thought, well, let me try this. So a lot of times I would add it or to some other thing, and they get better. And I think I kind of understood what bipolar disorder was, but not really, because it was completely new class of medication. And at the time, I didn't really think I saw a lot of bipolar disorder in my practice. It ends up I was wrong. It was happening. I just wasn't recognizing it at the time. But I started seeing that there was something else going on. There was something there. I just couldn't put my finger on exactly what was going on fully. In 1997, I've done a lot of speaking with companies who hired me to talk to primary care doctors about several different products over the years. But when there was in 1997, I went to a speaker training in Chicago on a medication called Zyprexa. And it was basically it was a conference to teach us about how to lecture about bipolar disorder to primary care doctors. Now that speaker training was the most significant I've ever been to. Most of them are kind of boring, but it's a nice place to get away and, have a nice hotel room and good food and drinks and, a nice little vacation. This one was different because this one the lecturers were throwing material out there that was just, I was looking for paper, I was taking notes, I was just like, what I was hearing, I hadn't heard this before. And I was enthralled with what I was hearing. And then I really realized then, and on the plane ride on the way home, I started to organize my notes and started to understand. I think I'm starting to understand what bipolar disorder is. And so when I got home, I told my staff, one of my nurses, I said, this person. So I had a list of names of people that I thought that I was confused about, or that I could only get them so far, and I wasn't getting them fully better. I didn't know why, and then I thought, okay, bring these people in my office because I think I have an answer for them now. So I started giving them Zyprexa, and it was miraculous. People would turn around from somewhat better to fully better. And that would happen again and again and again. And so the problem was with Zyprexa is weight gain. So it's the one in this family we call the atypical antipsychotic medications that causes the most weight gain of any of them. And I'm in Southern California. People don't tolerate weight gain here, especially women, sometimes, but men too. People don't tolerate weight gain. So when you see that happening, they would go off of it. And so I thought, okay, well, we still had Risperdal, and that was a decent one, but that had some side effects also that were a little bit problematic. It was better than nothing. But then, then after that, Seroquel came out. Now, Seroquel, really good medication, amazing medication. Actually, I prescribe a lot of it to this day. Great for sleep. Great for, it works very well for bipolar disorder. The problem with some people is that it works too well for sleep, and they sleep really well, but then they're tired the next day. And then sometimes we can't get the dose up to where it needs to because it's just too sedating. So that was the limiting factor on that. And then moving forward, we had, Invega, we've had Saffris, Invega, and there's several since then. Nowadays, we got Lybalvi, we've got Caplyta, we have Rexulti, we have Vraylar. You might hear of Vraylar and Vraylar and Rexulti and Caplyta and Lybalvi on commercials. They do TV commercials, so you might recognize those names. So there's several of them, and now Fanapt is another one too, a new one. So there's several since then that have come out, and they're all really good. It's just a matter of the trick with medications is trying to find the right medication for the right person that gives results but doesn't give side effects, or doesn't give side effects that are significant. Maybe a little bit of side effects, but if it's a little bit, not too bad, the person can tolerate it and is acceptable to the patient because the results are so good. That's a situation that's acceptable. So that was bipolar disorder. And then so what happened with me going into towards the end of the 1990s, going into early 2000, I had to make a decision because I was getting a lot of referrals, not only from patients, from psychologists, from other doctors, because I was starting to get a reputation for treating this. And I was just getting kind of overwhelmed in my practice. I was working way too many hours, working on weekends and having a family with young kids, that's not the ideal. So I really had to make a tough decision because I really enjoyed being a family doctor. I really loved all aspects of it, but I knew that basically this was my calling. I knew that I had to pursue this. I knew I was doing good in family medicine, but I knew I could do better, and I could do more good for more people doing this than I could being a family doctor. And and I've said this before on the show. You know, when you're a doctor, you want to help people. That's your mission, and I saw no better way of helping people than actually doing something that I ended up finding I was good at, and I was able to help a lot of people that weren't getting help from other doctors, even psychiatrists. And I had patients come in to this day even, and back then, who had been the primary care doctors, had been the psychiatrists. I love the patient, by the way, that's really difficult or at the end of the rope. I love the challenge of figuring out something that other doctors haven't been able to figure out. I love the challenge. I love the fun. To me, it's fun to figure that out. I said in my book, I think it was my second book, I called it's called The Human Being, the Ultimate Living Puzzle. I look at this like a puzzle. I've always loved puzzles since I was a kid. And I played chess growing up. I was in tournaments and playing chess. I was a ranked player, and I lost interest after a while of that. But I always liked that this puzzle and word puzzles and games and mazes and all this stuff. To me, that's what this is like. This is like figuring out this puzzle here, and kind of an intricate puzzle. But the puzzle is the human being, and the puzzle is and I also, in my first book, the last chapter is called it's the art of medicine, because it's also like art. It's I'm not an artist, as you can tell, obviously, but when it's the artistry of doing this. It's not just all science. You have to have it's artistic, because you have to think creatively. You have to think outside the box sometimes. And it's not just always cut and dry when it comes to this. And it's a lot of, you have to listen to your patients. And I think too many doctors rush patients in and out, don't explain things, don't listen to patients. I hear it all the time. The doctor didn't even look at me barely. It just wrote a prescription and I was out the door in 5 minutes. That's unacceptable. That's it. Doctors, if you're seeing a doctor like that, you really should look elsewhere. It's amazing to me. People will, if they don't like the grocery store they go to, they'll go to a different one. If they don't like their dentist, they'll go to a different dentist, probably. If they don't like their hairdresser, they'll go to someone else. But when they go to a doctor and they get bad care, somehow they feel they stay there, and they just put up with it, because I think they don't realize that there could be better. That's all they know, maybe, and they think, well, that's just the way doctors are, I guess. No, it is. Well, yeah, it is the way a lot of doctors are, but not some doctors. And I know a lot of really good ones, who aren't that way. And so you just have to find someone who listens to you and takes the time with you to understand. So when I in 2000, and another one, going back to medications again, an antidepressant called Lamictal. So Lamictal is the only antidepressant that works on GABA. But the other ones, gabapentin and Topamax, really focus more on the anxiety and pain. Lamictal focuses on depression, but it focuses more on what we call bipolar depression. So bipolar depression is people who are bipolar, but people with bipolar, they can get manic at times or hypomanic. And mania would be the psychotic thinking, racing the mind. But they also can plunge into like a deep depression. And the depression with bipolar disorder can be worse than the regular, we call unipolar disorder, which is we call major depressive disorder. It's a very deep and dark depression. It's also we call a cyclical depression, where they this and then they drop, and then they eventually pull out of it, and then they drop. And the patients sometimes they don't want to be taken. They don't want to get rid of the mania part, because they're having fun. They're spending a lot of money. They're doing all these things. The problem is, they want to ride that. They want to ride that wave for a while. But the problem with that, any wave, it crashes, and then they hate that part. And then they want to pull out of it, but they can't pull out of it easily. So that's Lamictal. Lamictal kind of helps with cyclical depression or depression that's just not getting better, with SSRIs or SNRIs or and DRI, the Wellbutrin. New one is called a Plenzen, the newer Wellbutrin, a name brand one. So the Lamictal is a very, very good medication. There's a new antidepressant out too called Auvelity, which works on dopamine. So it has a little bit of Wellbutrin in it, but it boosts glutamate. So glutamate and GABA are basically they're opposites. So we call GABA the inhibitory neurochemical. So it means it's inhibitory means kind of a calming effect. Glutamate we call excitatory neurochemicals. And glutamate is kind of a pick-me-up, energizing neurochemical. So when you combine the energizing effect of Wellbutrin with the energizing effect of glutamate, it's a very good medication. It's strong, but it can be strong in a good way. Where I use it is when I would have already tried Wellbutrin by that point. If I'm either if I see great results with Wellbutrin, I won't do it. But if I see okay results with Wellbutrin or not great results with Wellbutrin, then that's a really good new one that's available now. So what happened then is that in early 2000s, I was learning all these things, and at the time I thought, what do I do here? I've got to get the word out about this. So I started writing my first book in about 2002. And I thought it would be one book, and that took me about 4 years to complete. And after about 4 years, I had about 800 pages of book, and I thought that's too big for a book. And so I thought, okay, I'm going to split into 2 books now. So then I spent another about 4 years writing the second book, and that became another 800 pages. And I thought, okay, I can either release a really long book, which people then won't read, or I'll split it into a third book. So then I decided to do a third book, and that took me another 4 years. So between the first 3 books, so this is my first one, Healing the Mind and Body, the number 1, number 2, and number 3. So I call it the trilogy. My first 3 books took me 12 years, but during the 2000s, I just really kind of kept learning more and more about these things. And again, new medications would come out, like I said, and I would start to get more and more experience with trying different medications, different cocktails, combining things in different ways. Learning so much. And then when I finished these after about 12 years, I was trying to figure out, and then I've been very busy the whole time in practice, but I decided at the time, I was like, what am I going to do now? I really need to teach, because I think doctors really aren't understanding this. And, maybe these books, I thought, they're called, these are really for patients and doctors, but the third book is probably more for doctors, but the first 2 more for patients. But I really thought at the time, I really need to teach, and so I had an idea about maybe setting up a online training program for prescribers, for doctors. So I set off on writing after a little break. I said I'll start writing more books, and so I wrote 2 books. And that took me about maybe another 5 years or so to write the 2. And they're called the Corona Protocol 3 Secrets to Success and the Corona Protocol Prescriber's Guide. And currently I'm still editing them. I'm working on them as we speak. After that one, I thought, okay, now what? And I thought probably should be done writing books, right? But I thought about I thought about this one, the Corona Protocol. I think it's my best book. It's my favorite book that I've written. I started thinking I wanted to write something really different. I wanted to write a book about storytelling, and because I'm a fiction lover. That's everything I read is pretty much all fiction novels. And so I thought I love stories, and I think people love hearing and reading stories. So in this book, I tell 30 original stories about different people. Some of them are based on patients I have seen. Some of them are made up in my imagination. The full title is The Corona Protocol, a scientifically proven medical solution to stop addiction, bullying, homelessness, school shootings, and suicide, 30 years in the making. In this book, I cover the first section I cover depression, anxiety, bipolar disorder, ADD. Second section I cover PTSD, eating disorders, schizophrenia. We call treatment-resistant depression, so depression that's really hard to treat. The third section, I talk about personality disorders, so narcissists, people who are histrionic, like super dramatic, borderline. So people might have heard about borderline personality disorder, very, very chaotic people. And then sociopaths or psychopaths. Not only, these are very dangerous people. These are people that you really want to stay away from if you identify them. These are the criminals, but they're not only criminals. They're also people you would not expect that would be a sociopath. But sociopaths are basically people who have really no conscience. They have no empathy. If they hurt you, they don't care. They don't have feeling towards other people like you should. So these are not only the criminals, but these could be people like politicians, or a lot of them out there. They're sociopaths. It could be your doctor. It could be your pastor. I mean, it could be a lot of people who are very cruel. But you would never know that because they have this exterior about them that you wouldn't figure it out until. But these are also people who are con artists. They rip people off. These are that's sociopaths. And then in section 5, I tell my story. Which I'm doing to you now, but in further detail. So if you want more detail about what I'm saying right now in this show, you want to get my book, section 5, which is called Why I Love My Job. And then section 6 is basically I further tell my story. I also share a lot of personal information. I share some of the very difficult things I've gone through, and I decided to do that because I just to show that, hey, I can, I'm not immune to having some of these things too, and so I'm very honest in the book about what I've gone through, and so that's the Corona Protocol, and so and this is now available not only hardcover, softcover, and ebook. On Amazon, Barnes & Noble, and Walmart, but also now on audiobook. It's now on, it's called Audible, is audiobook platform that we have now on that one. So anyway, but because I know I had so many people tell me I only do audiobooks, and a lot of my ADD patients who have a hard time reading books, they want an audiobook. So I did it for them, and I'm glad I did because I wanted it to be available in all platforms. So that's where we are to this day, really. And so now my practice has just continued to be fully committed to this subject. Like I said, I want to get to the point where I teach doctors. My idea would be to have online, have a bunch of doctors online subscribing to my program, and then we have actual real patients coming on, and I interview the people, and then other doctors and also nurse practitioners and physician assistants who also prescribe medications. We call mid-level practitioners, where we all kind of are actually in real life seeing patients, talking to patients, and then we basically, after we're done with the patient, the person exits the scene, and then we talk about what do you think, what's the diagnosis, what's the treatment plan, and then we make a decision. I make the final decision. We do an intervention, then have the person follow up in a few weeks. So we'll have new patients, we have follow-up patients. So it'll be kind of an ongoing clinic. And so that way, I think you can learn stuff reading my books, but if you want to have a real hands-on experience of seeing it in real life and seeing me doing it in real life, then I think those other 2 books I'm going to be releasing will be, I think, hopefully well received. So that's kind of my story in brief. I could go on and on about more detail, but that's pretty much the crux of it. Like I said, I'm really glad I made the decision I did. I think it turned out well. I'm dedicated the rest of my career to this subject and teaching and treating patients, and I love doing it, and I'll continue to do it as long as I possibly can. And thank you for listening. And like I said at the beginning, if you like what you see, please subscribe to the channel. Please tell your friends about it, and please share it with others. We really want to grow this. And I think the more people that sign on, the better, because I think there's a lot of people out there that are really curious and they don't really get this information elsewhere. And so I'm happy to help with that, and any way I can that can help people, which is my goal. I love doing it, but the thing is, what I feel is that I can only do so much, and what's always driven me is that I know there's so many people out there that don't have access to the right care, and that could get help, but they don't have that help available. So that's why I want to teach, so that more on a larger scale, that doctors can learn these methods and help their patients, and so that I can kind of pay it forward. But thank you for listening, and thank you for joining the show.